Good morning. Everyone can hear me okay? Do we have a good sound for the online audience?
Yes.
Good, excellent. So good morning, everybody. This is my second half. Those who come to Cranouts regularly, you may recall that about half a year ago, I discussed some aspects of autonomic dysfunction, and the whole idea would be to looking at the non-motor presentation of Parkinson's disease. So very briefly, nothing to disclose, and you already seen the CME code. It will be shown a few more times, so don't worry about it if you haven't caught it. And again, just basically talking about overview of these symptoms, but also the management strategies. So again, when we kind of think about Parkinson's disease, I repeat this slide from last time just really for refreshing. I just really get us going. There are so-called cardinal features, and there are motor features. So we basically, I work in a movement disorder clinic, or disorders clinic, but of course we deal with much more than movement disorders. And there are some additional secondary motor features, but again, at this point, the diagnosis is based on motor symptoms, even though clearly Parkinson's disease is essentially a systemic disorder. Again, this is the sort of, again, for refresher, the old idea, or still valid idea, there's a striatonigral degeneration with the loss of dopaminergic neurons. Is a substantia nigra pars reticulata, which is kind of with a loss of neurons and Lewy bodies, but this is obviously counts only for minority or important part, but not all symptoms of Parkinson's disease. Again, I already mentioned it before, just for refresher, one of the ideas would be the spread of disease through the brainstem. Actually, the first nucleus involved tends to be dorsal nucleus of the vagal nerve, which really begs a lot of questions, whether there may be some connection between the gut and the brain. Actually, there's a concept which is kind of still controversial, and we won't talk about today, brain first and body first. For Parkinson's disease, again, I did say last time that I will talk about new classifications, but kind of realized we haven't covered the second half. So again, I'm not trying to kick the can down the road, but we will talk about new classification. Again, also talk about the concept brain first versus body first. But again, this will be more clinically based or clinically focused talk, looking at the whole gamut of phenomenology with Parkinson's disease. Again, so there are sort of 6 stages, but when we would sort of consider somebody would have a clinically evident idiopathic Parkinson's disease, this would be Bragg stage 3. And again, I already talked about it, so again, just for refresher. And again, I like this slide, had it before, but again, this is correction from 64. The attribution of such a complex clinical syndrome to a rather small and homogeneous structure, a substantia nigra, hasn't appeared logical. So obviously there were some, thinkers and steerers who thought about it. And again, if you think about actually it's a tremor, but actually would be the tip of the iceberg, would be motor symptoms. But again, there is a lot of different things, underneath. And again, as we remember, this part below sank Titanic. So this is kind of important part of the iceberg. So which are those again out? So this is just kind of, and again, this will be, so again, we talk about, I spent last hour, the whole hour rather, talking about autonomic dysfunction, so we won't talk about it, but I'll touch base on about cognitive problems, behavioral problems, sleep, which is very important, fatigue, and so abnormalities of sensation. So again, this is so one thing is the behavioral dysfunction in Parkinson's disease, and there is this concept of Parkinsonian personality, which is interesting. I'll talk about it more in a second, because again, the question is, when does Parkinson's disease as a clinical entity start? So again, I mentioned when we see these patients, with apparent motor disorder, which we can diagnose with the idiopathic Parkinson's disease. If you kind of look at the Bragg staging, would be stage 3. So in the middle, basically, when you have when it has affected the substantia nigra, which is obviously brainstem, upper brainstem, but there are definitely some features which I also review today, which may precede the onset of motor symptoms by decades. Again, REM sleep behavior is a good example, and I'll discuss that. So Parkinson and personality is something similar. So what is the chicken? What is the egg? And again, it's somewhat controversial, but I think it's interesting that whether these patients, again, we think it was about 20 years before we sort of would see them, it would present to us. Depression and apathy and anxiety. Actually, we have our colleagues here from neuropsychology who are our great colleagues helping us with this assessment and treatment of these symptoms. So actually, this is very pertinent to you. Anxiety, again, this is not to say that anybody who has anxiety, will have a Parkinson's disease, but again, and it has to do with the sort of, if you kind of think about it very mechanistically as a monoamine disruption, synthesis disruption. Dementia is an important part here. However, if you recall diagnostic criteria, if dementia either precedes or the onset of motor symptoms, or appears within the first year of the appearance of motor symptoms, we would classify this as a Lewy body disease. Again, this also deserves the whole hour talk. I tend to be a lumper here as a splinter, but clearly this is something what's happening. But as when I was a fellow with Dr. Friedland many years ago, I believe we had a first case described in literature of Lewy body disease. We didn't get much traction, so it was kind of lost in translation. But we had a case report. Actually, had only two citations, which is kind of very maddening. But I believe this was the first case described in literature, even though, again, it didn't get a traction as that. When we had a case when sort of, again, the title of the paper was, dementia preceding the onset of Parkinson's disease. We didn't, of motor symptoms, we didn't use Lewy body disease. And again, it was somewhat forgotten, but am I bitter about it? No, but would it be sweet? But again, this is what it is. And of course, then last but not least would be dopamine-induced behavioral dysfunction, because obviously we use dopaminergic stimulation very, very routinely and very robustly. And again, there will be some propensity of the dopamine dysregulation. These patients may develop quite catastrophic behavioral problems. So again, I mentioned this pre-symptomatic Parkinson personality, sort of industrious, serious, kind of introverted, stoic, not very seeking novelties. Sometimes, I'm never on time. Actually, I'm so relieved. Look, I'm never on time, so I'm not very punctual. Actually, I'm quite opposite. So that's a good sign for me. But somewhat rigid. Again, this is something what has created a lot of controversy. But again, the thinking or the idea this was proposed is that again, there may be some stability and some sort of a process which takes years, how it sort of affects the brain and its biochemistry before we would have would we consider Parkinson's disease as a movement disorder, which is kind of probably in 20 years, those of you in residency, we kind of think about Parkinson's disease differently as it is now, even though for practical purposes, still treatment of movement disorders is really, whether with the medications or deep brain stimulation, is really very, very effective. But again, we are getting to the era of prevention and prophylactic treatments. So it's really a totally different ballgame. And again, looking for these red flags, because it's very difficult to diagnose these patients, is very, very important. So this is just this slide would deserve 1 hour conversational discussion. Again, so there is the issue of that these symptoms may precede. Again, we have to be very careful if somebody's sort of rigid or not very flexible as a personality. It doesn't really mean that there is there is Parkinson's. There was proposed that people who end up being preachers / priests, there's again we have a few, but again epidemiology is not very clear. But again, there is this kind of a type of personality which is more susceptible. Again, how to differentiate who is really destined to have Parkinson's disease versus who doesn't. We wouldn't do it by proper psychological testing. It probably would be by assaying of alpha-synuclein levels, but again, we are not there yet. Depression is, of course, very common, as sort of as an entity, but it's the most common psychiatric problem in Parkinson's disease. Affects about half of the patients, and again, may precede the other features. Again, similar stories, Huntington disease, when again, this depression. So again, so a lot of neurodegenerative conditions may, I don't know, rather do affect overall functioning of the brain. It's important. This is not related to it's not related simply to disease duration or severity. So a lot of patients who are really very depressed and have relatively mild or well-controlled symptoms and vice versa. So again and again, it would be sort of this kind of monoamine disruption, serotonin, norepinephrine, good examples of monoamines which may be affected. So again, this is important that we need to treat this symptomatically, recognize that treat symptomatically. Anxiety can be very prominent, and sort of pessimism is a common feature. Again, they are not necessarily pessimistic that they have a Parkinson's disease, but also they have a lot of somatization, even though suicidal attempts tend to be less common. There is some controversy, and actually I mentioned Lewy body disease, and Robin Williams committed suicide. Was it 5 years or something? Actually was kind of really was a lot of conversation about that, even though it was Lewy body disease. But again, it would be more impulsivity than depression. Same thing is for Huntington. Again, I keep coming to Huntington disease because I was just last 2 weeks working on a grant to renew our Center of Excellence. So I was just reading Huntington disease all the time. And again, same thing is that it's more impulsivity than depression, what really would be a risk for suicide. So again, this is not commonly very important. Is also think about daily fluctuations. When these patients have motor symptoms, they may fluctuate. So we talk about on and off phenomenon. When the patient is well controlled, we would consider them in on, and when the medication wears off, they would be so-called off state. So again, I'm referring to the motor symptoms, but many times this. So again, depression typically we would say should last more than 2 weeks, sustain more than 2 weeks as a classic definition. But this patient may feel more anxiety and sort of worse when the medication, not only motorically, but also have this sort of psychological reaction. And again, it can be really sometimes very clearly correlated to the motor fluctuations, which basically we think is related to the actual dopamine, levels in the brain, even though we don't measure that directly. Apathy is probably, well, not probably, but definitely something what is extremely difficult to treat. And actually, I see, again, we have 2 residents here. Well, I mean, we have more than this, but I'm looking at 2 young gentlemen. So we've been talking about hopefully some project, Dr. Underwood's group, about apathy and DBS. So this is something very important and also be very, very worthwhile looking into. It's important that apathy is not equal depression. It may, of course, coexist. And actually, there's a very interesting paper where apathy can coexist with the impulsivity, which, like you would say, doesn't make sense, but it does, because again, so impulsivity is more sort of able to controlling urges, but apathy is overall reduced sort of motivation, diminished motivation, lack of initiative, really lack of concern. So, but it's not classic anagnosia, or like you would sort of consider. But it's more, or not even denial of symptoms, but it's just kind of basically lack of concern, indifference. Again, it's up to good 30% patients, I would say. And again, as I said, it's not simple reaction to disability. Again, it also may fluctuate more of symptoms, but again, these patients tend to be, apathetic more, most of the time. Again, they may be more or less. I find probably the most difficult to treat. One thing could be very simple thing like having a calendar where you would even write the mundane things. Okay, at I don't know, 8:40 in the morning, I will walk to the mailbox and drop the mail for today, and then I will go with the garbage can. I will take out the garbage. I mean, at 10 o'clock and things like that. It helps. I mean, it's sounds very silly and very laborious and very mundane, but this may something be. Stimulants typically don't really work for that much, and also they can worsen more symptoms, obviously. Anxiety is another common, and of course, anxiety, as I mentioned before, may precede motor symptoms. Again, I'm not to say or suggest that anybody who has general anxiety condition, is destined to have Parkinson's, but again, there is a higher risk in these patients. It's often associated with depression, but can occur independently. And again, there is no correlation with the disease severity. Actually, many times this patient may have relatively mild and suddenly would be described as anxious. And of course, we see patients with Fraser when, for some reason, this traffic, I mean, it's not that bad, but it can be like a lot of, and parking, actually, we have quite a few patients who almost had a panic attack with the parking. So I'm not sure it reflects on our parking system, which is kind of, or a disease, or rather both. Again, it also can happen in the off time of phenomenon. Same thing I mentioned, when these, medications kind of wear off, the effects of the medications wear off, and these patients would experience more anxiety. Again, SSRIs, we kind of really try to stay away from benzos, but SSRIs can be helpful. Basically, we treat as other types of anxiety, but again, also the optimization of motor control can be very helpful for these patients, especially again if you have these fluctuations. And again, this I would like to kind of again re-emphasize this concept of non-motor fluctuations. So now cognitive decline, I already mentioned that if dementia rather, cognitive decline precedes the movement, all sort of movement disorder, we would sort of classify that somewhat arbitrarily as a Lewy body disease, but this is something what would typically happen later on. The estimates are really very broad. I mean, zero is of course nonsense, 100% is nonsense, but averages, upper 30s, I think is probably close to half patients. And again, it also depends how we assess that. Of course, we have our neuropsychological colleagues here who may chime in, but there is definitely, it has to do with the disease progression, and actually the prevalence could be close to 40% in 10 years. So there is this correlation with the disease duration and severity. A lot of these patients would have an MCI, or mild cognitive impairment. It's actually much more common than in full-blown dementia. And again, also the question is, of course, in terms of dementia, whether there is underlying mixed pathology, especially with the amyloid burden on top of Parkinsonian features versus I had actually quite a few patients I did spinal taps who developed mild dementia, have Parkinson's disease, and actually many of them actually have normal tau and normal A-beta 42 levels. So again, this is many times independent on the underlying pathology. I mean, underlying mixed pathology such as Alzheimer's disease. So the dysfunction is, kind of think about, the old concept was subcortical dementia, which somehow went away, even though I used to like it. And it's kind of so again, prototypical would be Huntington's disease and Parkinson's disease. And I'm not sure why, but somehow kind of faded away. But it's really more this kind of frontal, excuse me, frontal type of problems. So again, impaired retrieval of information. When I talk to my patients, I always sometimes describe these problems that, if you think about your brain as a sort of slow computer, that it's there, but you have this old, nobody has a 386, but it's an old computer which is kind of really, it's just there, just, doesn't get really retrieved fast enough. But also impaired problem solving, multitasking, again, reduced initiative and motivation. I already mentioned apathy, so it's really coexisting. And again, difficulties dividing and shifting attention. So again, it's kind of really what we would in old times call subcortical dementia. So executive dysfunction again is, and again, a verbal fluency. So we do MoCA test as a bedside testing, which actually has a, that's why MMSC, for instance, is not very suitable tool as a bedside monitoring, both diagnostic and monitoring tool, because it's really heavily weighted on memory, so it's really more suitable for Alzheimer's disease, if at all. But again, MoCA, would be Montreal Cognitive Assessment, would be, and again, also the verbal fluency, and also when we sort of see these patients or send this patient for neuropsych testing, whether it would be before DBS or after DBS or unrelated. Again, this word finding and retrieval is you can do at bedside, you can do category animals or FAS test usually. So, but it's kind of really, there are some norms. But dementia is also, cognitive decline is also very important because it it's a risk factor for developing other symptoms, especially psychosis. Again, I'll talk about psychosis quite more in a few minutes, but again, they may exist independently, but again, this would be an important risk factor. So in terms of treatment, rivastigmine and donepezil were actually developed for Parkinson, for Alzheimer's disease, apologize, but they actually tend to be much more effective for Parkinson's disease. Again, there is evidence of cholinergic degeneration. If you look at let's say PET scanning, looking at it, so you have also this posterior degeneration. I didn't mention one problem would be visual spatial problems. That is also very typical. My favorite example is actually a true story of my patient from Vanderbilt, who he had a small company, I think, and they sort of had a building with their own side parking lot, parking spot, parking lot. He also had his own parking spot, and his secretary, without telling him, would started, a few years ago, always reparking his car because he just couldn't park into the simple. And it wasn't any kind of parallel parking or anything like that, but just basically completely disruption of visual spatial problems. Also, it's important for driving, especially when you trouble staying in a lane. And so that's very important. But anyway, so rivastigmine is actually now approved. And again, I would also point out that I tend to push doses higher. Of course, you have to be careful about cholinergic or muscarinic side effects, especially GI. But if I use donepezil, so again, this is actually about 1/3 more effective than for Parkinson's, as I said. For Alzheimer's disease, I apologize. So again, it's more effective for Parkinson's disease, for Alzheimer's disease. And for instance, I sometimes push doses relatively higher for donepezil, sometimes even 30 milligrams, so which is basically off-label. And of course, you have to be careful this patient don't have any muscarinic GI problems. I did mention psychosis, which is sort of interesting that so hallucinations have been known in this condition, even though this kind of concept of psychosis was really introduced at the time when new medications started to be tested, especially pimavanserin. But this is actually very common. Again, as I said, dementia may be a risk factor for the developing of hallucinations. However, it is absolutely I mean, it's seen and common, they can coexist independently. So there are several uh, features or several components of what we would call PD psychosis, which basically would be disrupted perception of reality, again, hallucinations, which are almost always visual. I mean, we don't, I mean, sometimes especially we talk about auditory, even though it's there. I mean, if of course, if you have a pure auditory, that's really very red flag. This may not be related to Parkinson's disease. So, I mean, again, these patients may also report some, but it's mostly sounds. It's not like somebody give them voices, go to Parkinson's disease clinic and kill Hedera. I was only threatened to be killed by Huntington's disease patients, so I'm still here. But no Parkinson's disease patient of mine threatened to kill me. So again, that's more domain of HD, but it's a different story. But these hallucinations also may vary. So it doesn't have to be necessarily that patients would sort of report that there's somebody in a room, and some of these hallucinations are actually quite pleasant. So this, so that's very important to, not all the time. And also it's very important because many patients would and caregivers would confuse hallucinations with REM sleep behavior. So here the patient has to be fully awake. So there is a phenomenon of hypnagogic hallucinations, but again, this would be sort of really unrelated. So can go with a sundowning, get more, but also many times they may be a feeling of presence. You may have walked, down the, street, and you felt maybe somebody next to you, and it wasn't nobody was there. Again, you don't worry. I don't think they are developing Lewy body disease, but so it can happen. But again, it can start, and this feeling of presence is usually first symptom if the patient is able to articulate, well, their symptoms. Delusions are, of course, more disruptive behaviorally, and again, holding some false, typically paranoid, obviously, I'm from a country where Kafka was born, so paranoia is in our blood, that's our norm. But again, so this will be disruption. It can be very paranoid, especially if it's a turn against the caregivers. And I would say that delusions are much more difficult to treat sometimes than hallucinations. Again, as I said, hallucinations can be sometimes essentially pleasant. Sometimes I have some, ladies who see, kids, and they just talk to them, because it's extremely disruptive for caregivers. So that's actually important when you look at the burden of these. You need to look at it also, how it's disruptive for patients, because the patient is your main sort of, focus. But of course, don't forget about burden on caregivers, which can be extremely difficult and high burden. Illusions, again, I mentioned those things are not there. Also, I would come to the visual hallucinations. You mentioned can start, you would see this kind of speckled, especially if you have like speckled floor, carpet, or other materials. They may see that it's a bug. Again, sometimes patients may feel, I have patients who saw snakes everywhere, stopped eating because snakes were in the food, in plates, lost a lot of pounds. So we have to look for these things. And again, can be some escalation from this false sense of presence to really full-blown hallucinations. If we start to think about it, and actually there is a lot of misconception about that this is medication. I mean, so it's the disease. So it's very important because when but again, medications, as you see here, do play some role. So if the patient develops psychosis, we need to also really look for especially in a relatively sudden manner, you need to also think about medical factors. UTI in our practice, we always sort of tell, just if something really sudden, but also, we have to be also aware of situations that you may have not, discovered or uncovered. These hallucinations can have kind of like this false sense of presence, and again, things just escalated. But think about again, UTI or other sort of, during COVID was relatively common. Again, I mentioned medications again, and of course, actually, a lot of providers who don't really deal with this would, suggest to stop the medication. Again, we sometimes look at the medications, and some classes of medication, especially agonists, And we don't use anticholinergics almost at all. I mean, I have a few patients who have a really intractable tremor where we still would use trihexyphenidyl, and but it was last resort. But it's it's a really handful of patients. But look at so again, from Parkinson's disease point of view, amantadine is a very common of any form of amantadine, which is actually used for both off time and dyskinesias. I mentioned agonist. Again, when we talk about agonist, they are actually we are talking the class at this point is D2, D3 agonist. And again, D3 action would sort of trigger hallucinations. Just for information, there is a new class of coming medications of D1 agonist. So which actually also there also D1 receptors are more part of the direct pathway versus D2, D3 are an indirect pathway. And actually D1 agonist would have really hardly any hallucinations. The available agonist at this point with the D1 is apomorphine. And again, they typically don't cause hallucinations. But of course, the other non-PD medications, so, you have to look at that. So always that's why I look at if there was any change in medications. That's usually would be special medications which have a higher potential for anticholinergic effects. But again, alone, it's really the brain degeneration. So it can be some interplay between medications and and the disease. But again, even if you withdraw all medication, which obviously is not practical on this patient with off time, and actually there were some cases, especially I'll talk about pimavanserin in a minute, that this patient actually really succumbed to disease because they fell and had injury. But that's important. And also with the Lewy body disease, where we see these hallucinations relatively early, they may happen independently. But again, it's good to look at these medications. But again, also practically, if you have a patient who suddenly develops relatively suddenly, always look for medical problems. So again, urine analysis, sometimes blood culture, urine culture is something what we typically do and recommend to do. Again, this is actually what I just said. And many times, basically, what we end up doing, we would definitely treat this with neuroleptics. Now, again, this is sometimes I would consider this, compare it to story of Mr. Jekyll, Dr. Hyde. I mean, nobody dies in this story. I mean, that's better not be lethal component of this story. But again, it's excellent example when we try to increase dopamine activity, again, mostly stimulating D2, D3 receptors. Again, we don't have much for D1 yet, even though they are coming. And sometimes we need to block them. So it's very important. There is this concept of classic and or first generation versus second generation and neuroleptics, which again still would be dopaminergic. So really, I only use Seroquel or quetiapine. Sometimes you have marketing. Abilify apiprazole is the most common problem for me because it's so widely prescribed in terms of both tardive dyskinesia, of course, but also so I think they have a too strong, has to do with the receptor occupancy and dissociation factor. So basically, but quetiapine basically, and followed by clozapine. Clozapine is excellent choice. As you may know, it can cause agranulocytosis. So there is actually a very strict REMS. Actually, I'm registered, so I can prescribe. Actually, we prescribe that. Not maybe more than some psychiatrists again, but again, the REMS requires blood draws for looking for neutropenia. So for, every week for 6 months, so first half year every week, then it's bi-weekly, second half of year, and then you can go to monthly. So it's a quite significant burden, but again, clozapine has a little bit of anticholinergic side effects, which you have to be careful with cognition. But again, I think that's a very good choice. But again, quetiapine has been sort of useful. And again, we usually use lower doses. Most of our patients will be 25 to 50 milligrams. I mean, it can be higher than that, but you don't typically see 500 milligrams of quetiapine that would be prescribed for psychiatric indications. And again, I think that there's some evidence that you can see some negative motor impairment, because that's a really important part that, these neuroleptics would not cause any negative motor, influence, which will be from the blocking of D2 receptors. And again, for quetiapine, it's estimated it's about 300 milligrams per day. Pimavanserin is a new option, which is actually non-dopaminergic, a non-dopaminergic option. And again, it's kind of really now settled. It was actually approved in 2016. I don't believe it's almost 10 years. And again, it's basically antagonist, inverse agonist at serotonin, 2A receptors. So it's actually was actually tried for schizophrenia, didn't work, and but again, main advantage would be that has no, even though I had one handful of patients who claimed they couldn't walk or be on answer, which is kind of really hard to explain, but of course you have to listen to your patients. But also they are not sedating. Quetiapine is actually quite sedating, but I can sometimes use this medication based on comorbidities. The patient, especially if they have psychosis, they may not sleep, and you need to really break that. So quetiapine, which can tend to be sedating, and again, could be a problem if the patient needs to stay awake. But again, if you need to induce sleep or help with the sleep, so sometimes you can tailor this medication based on comorbidities. Pimavanserin takes up to 3 weeks to work about. So sometimes you may, but that's why what I've done, that I started to treat these patients relatively early. So when these patients start telling me about feeling of presence, so you don't necessarily need to jump the gun and start treatment. But again, I sort of moved a little bit more, being more proactive, because again, if you may have a risk that if you kind of, and it's okay to observe this. Again, I don't necessarily suggesting that you need to treat it right away. So it's kind of a judgment call, but you may sort of having this kind of high risk of this suddenly precipitous like worsening, especially if there would be any kind of underlying medical problem. Again, obviously it comes with the black box warning, even though it's more, it's a class warning, even though you may remember a story, was I think 2018, when there was this question of, again, this is sort of basically just looking at, from their SAPS PD, which is the pivotal trial, showing improvement in terms of the, it's sort of this kind of scale for psychotic features. And again, you see that what takes about here maybe 2 weeks, but again, really I said good separation of three to 4 weeks. So again, just warn the patient or bridge them with a maybe fast-acting medication such as quetiapine. Again, so this is sort of a again, this is the question was whether there's increase mortality, and of course this is the question. But think about it, that actually pimavanserin actually performed better than other atypicals. Actually, was really was there was almost some experts thought that the mortality is higher, and there were calls to withdraw the medication, even though analysis showed that if anything, pimavanserin has actually better survival because it has less side effects. Again, think about it that in general, the emergence of hallucinations, or PD, as we would now say, PD psychosis, is almost like a reflection, or unless you have a very clear medical problem, or you have a clearly that you edit amantadine and the patient hallucinates, you take it away and hallucinations go away. But if they are sustained, again, you wouldn't stop the levodopa or reduce, because then again, it would impair motor function. So this is a kind of essentially a bad sign, kind of really more hallmark of advanced disease. But again, many times you need to discuss black box warning, and there has been some misperception or misconception about whether these neuroptics are actually dangerous. Sometimes when you have patients in nursing homes, they have their own regulations, and has been really going back and forth. Even though not treating psychosis is very important. But again, the idea was that pimavanserin was first thought to be having more negative impact on survival, but again, actually comparing to other atypicals, mostly quetiapine, most providers with quetiapine actually outperform slightly, but again, so it doesn't show any higher risk. Looking also additional features of psychosis is a busy slide, but especially first half year, short-term pimavanserin would be more beneficial based on looking at the different aspects. It's a little bit maybe less obvious after half a year, but again, so you on your left, this would sort of more favor pimavanserin, but again. So I think that it's really take-home message is that it's not really any kind of you have to monitor these patients, and again, the mechanism of mortality is usually cardiac, so measuring QTC. We don't do EKGs routinely, so if you have QTC more than 470, you should be very careful, even though it's still interesting whether you would do these EKGs regularly. But again, I usually about 450 getting sort of concerned, even though, for instance, VA would require, before I prescribe, that we have to, VA has a requisition, or there's a requirement rather that you have to have an EKG. So again, we don't do it routinely completely, but something to consider in your practice. So this is something what is especially impulse control behavior can be very spectacular. It has been about 15 years when there was a lot of attention about gambling and Parkinson's medications, mostly agonists. But dopamine dysregulation syndrome actually would really lead to excessive medication use and then withdrawal symptoms. So these patients tend to, sometimes we give these patients some leverage, so we can take extra medication if your symptoms are worse. So this patient, and have to be very careful and watch how they use medication. It could be sort of euphoria when they are on and dysphoria when they are off. And there's impulsivity and compulsivity up to really almost like hypomanic behavior. So one thing is, of course, to really look for the use of medications, but and again, not everybody has it, but especially if the patient would really report that I need more medications, and so that's why it's sometimes very useful to see them when they are on state, and you may sort of see they look almost like hypomanic. So impulse control behavior, I had a few. My record is $1.5 million. I mean, it's not my record, but no, seriously, there's a patient of mine who also was a transplant patient, so he had a double kidney transplant and pancreas. He had severe diabetes. So he was double transplant. He was on some steroids for transplant, plus had very severe Parkinson's disease, and he never disclosed. He spent he spent $1.5 million on sexual services. Let's put it that way. And he was telling his wife that I'm aware and I approve. And so his wife was extremely mad at me. I mean, of course, like I didn't know that, so it's important to ask. And but of course, he was coming by himself. So when you use these medications, it's good to, especially caregiver. And I may introduce the question. This may sound unusual question or weird question, but it's not how much they spend again. It's just, they had obviously significant means, even though, almost bankrupt, and they survived. But it's not about money. There is no threshold. I have patients who would get a $20 and they have to run to the gas station, buy those scratch tickets. So it's not about money. It's not about the amount. It's that impulsivity, pathological shopping. I have another patient that wasn't my patient. That's why I don't put it as my sort of, he at Vanderbilt, he bought Lamborghini, and actually he put it on credit card. It's about $220,000 car. Of course, this was way above his means. He wasn't any movie star to justify that car. Plus, the insurance was about $30,000 per month. Of course, hypersexuality can be very, 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 very difficult and very disruptive, even potential criminal behavior, unfortunately. But also sometimes funding behavior that it would sort of be indulged, repetitive, seemingly meaningless or semi-meaningless. I had a patient who tends to paint rocks, but he would be, just sort of funding behavior. Could be compulsive eating. So if you see patients with a weight gain, of course, sometimes you consider if especially use any antidepressants could be the reason, but actually if you look for these, but always ask for that. So it's always good to have a caregiver to confirm that. And I always actively ask for that, of course. Obviously, it's hard to know that I don't ask for their credit card receipts, obviously. So that would be disclosed. So they have that story when the patient told his wife that I prove, of course, it's not true, but it can be catastrophic, both financially and psychologically. So again, they were described, actually, it's interesting. It's not much less another reason we would use dopaminergic agonist is restless-leg syndrome, and you see it very, very rarely. So it has to do the milieu, the landscape of Parkinson's disease when you see this more gambling. So it's extremely rare in RLS. Of course, you have this phenomenon of augmentation, so there are some issues with dopaminergic regulations in RLS. But again, it has to do with that sort of really disruption of the hypersensitivity of receptors, because a lot of these medications we use are in a very pulsatile. And again, if you kind of think about the reward system, dopamine playing, that's why cocaine is one of the, so it's sort of same sort of amygdala sort of system, nucleus accumbens, and those are basically, again, more side effects of D3 activation, mesolimbic sort of system. And again, it just we don't have a clear-cut risk factors for that, so you just have to really look for that. Fatigue, very difficult to treat. It's chronic tiredness. If you have to look for medical reasons, kind of impairment of physical, mental energy. Again, my least favorite, favorite symptom to treat, again, ranked by worst, by patients, by by 30 respondents, they were caregivers and patients. Again, may coexist with the depression and anxiety, so we have to really be very careful. I'll try to tease it out, but of course, independently. And sometimes some medications may, indicate, may aggravate, especially agonist. But actually, I believe that the best treatment for fatigue is exercise. It really kind of doesn't make sense, but it does make sense. Actually, there are some emerging data that it can, so that's why I recommend regular exercise. Kind of course, the patient, would bitterly complain that they are tired and have to really, carefully sort of set up the program. But because also physical activity is very important. And again, it looks to us that really, again, somewhat counterintuitively, exercise is best for fatigue. Again, it's really because uncertain, so it has to probably do with also abnormalities of energy production. Sometimes these patients have a very significant weight loss, even though have a relatively normal calorie intake. So we just don't fully understand that. But again, it's just hard to treat. Sometimes stimulants can help a little bit, even though modafinil, I usually use non-amphetamines, modafinil, if you can get it, because amphetamines can worsen the tremor, but modafinil tend to be somewhat useful, even though it's just difficult to get. At least has been our experience last few years. Again, I already mentioned, I don't typically use methylphenidate, but modafinil can be of use. But again, the exercise is probably the most useful. Again, for those who need a code again. And let me, we have kind of running out of time, but let me talk about REM sleep behaviors, the last but not least. So this is basics again, but basically kind of think about the REM is when we dream. And so, of course, it's the sense for rapid eye movement, but there is definitely underlying or associated hypotonia. So it's not paralysis per se, but basically you can think about this as a disruption of this REM sleep stage associated hypotonia. And basically what it is that this patient would act out dreams. So there are some, of course, some other, you don't have to necessarily do a sleep study all the time, but it can be sometimes violent. Again, I like these anecdotes of my patients. One patient had a recurrent dream that he would encounter a bear in a wilderness, and he would fight. In the dream, he would decide to fight the bear, and he would kind of strangle the bear, and basically he was strangling his wife. There is absolutely nothing Freudian about this. And so there can be injury to patients or to caregivers. But also very important part is that these patients don't have a good restful sleep. They basically spend 8 hours plus, but they so just a patient yesterday, and his wife, his caregiver, described that he has a party a whole night. So he would laugh, talk, 8 hours from sleep. So her sleep is gone, but also patient feels very fatigued in the morning, even though I was in the bed 8 hours. So that's basically it. It's important in may herald the onset of cognitive decline, but again, the data showed actually that Daniel Claassen, my friend and colleague from Vanderbilt, was lead author of the paper, preceding up to 30 years. So these patients have very high risk. I have a few patients in my clinic who have a pure REM sleep behavior, and if they live long enough, they will get Parkinson's disease. Almost everybody. Again, the idea is do you live long enough? So we're going to proceed up to 30 years. Now, so this is again would be the idea of the lack of hypotonia during the REM sleep stage. But again, it's important that not all is RBD. Post-traumatic stress disorder syndrome. Sometimes, alcohol use can use it. So again, if you had a nightmare or talk from sleep, don't worry. But again, recurrent. And I always ask, talk about as a question. So does he talk from sleep? Oh yeah. And so when did it start? Oh, we've been together 20 years, and he always been like that. So that's very important. So I think this will be my last slide, because again, I don't know, I don't want to have this like stories of what is the 1001 night when Scheherazade never finished the story to avoid execution. So I didn't finish the talk again, but I don't think, well, next time we'll talk about synergy classification. But again, so the treatment, I think it's important because some experts sort of kind of almost ignore it. I think it's very important because again, it can contribute to fatigue and daytime sleepiness. Melatonin is the first one over the counter, and also gabapentin is not very well proven, but clonazepam is a long-acting benzos. Actually, it's one of the probably 70% of my clonazepam prescriptions are for REM sleep behavior, because basically benzodiazepines would change the sleep architecture in these patients, and again, it would be non-REM, which can be disadvantaged if you use benzos as a sleep aid. But again, here, this is what you want to achieve, that you want this patient in deep non-REM sleep, that they don't really, not only get a better sleep, but also that don't injure themselves. And I have a few patients with spectacular injuries from sleep, where they would do this just like, there are bizarre stories, really. So again, this is something but again, think about it, if you see somebody who would describe that, they are really developing alpha-synuclein disease. Actually, they are the possibility they develop multiple system atrophy, which is another alpha-synuclein related pathology. And let me stop here because again, I think that we have still 20 slides to go, but again, this was what I wanted to cover. So I think that so this kind of concludes. I don't think I will do. I promise I won't do part 3, even though there are a few slides left. But think about it, about this condition or conditions, number of symptoms, that they are really so kind of thinking about Parkinson's disease is a really systemic disorder. Again, first talk about half a year ago, we talked about mostly autonomic dysfunction, orthostatic hypotension, neurogenic orthostatic hypotension, gastroparesis, constipation. Again, we talk about now more. Again, sleep would be very important of cognitive problems. So it's interesting that those who we treat Parkinson's disease start to wear more and more hats. You may use for some help for other specialties, even though we typically try to manage them, most of them ourselves. But it's a very complex disease, and also always look for these symptoms, because sometimes patients would not volunteer that they have that. And also sometimes can be very, very useful, specifically when you have I mentioned REM sleep behavior would be very, very, very almost pathogenic, for the alpha-synuclein. So especially if you have a multiple system atrophy type C. So this is of course a different story, but it has to relate to that this is alpha-synuclein pathology, and it's a multiple system atrophy. C is for cerebellar when you have a patient with ataxia. So I always ask, especially if it's not family history, do you get a history if there is any suggestion of REM sleep behavior, do even a sleep study, because if there is a REM sleep behavior, it's MSA and you are done diagnostically without skin biopsy, anything like that. So these things can be very, very useful for diagnostic purposes, but also be really aware of them, and they can be treated very effectively. But again, it's becoming sort of more complex treatment, and again, looking for these signs and symptoms, is very important for good patient care. I'll stop here. Thank you very much. I'll stop sharing.
Peter, for the comprehensive view. And just as a starting note, I was a neurology resident in the 70s, and our chief was Melvin Yar, who was a ANA president and very active in Parkinson's, and he believed that Parkinson's did not affect cognition. And he was wrong, and the main problem was they weren't interested in the drug. They just paid any attention to it. And it was a horrible bias. So we know from Brock, as you mentioned, that the dorsal motor nucleus of the vagus is quite early. But what about the sensory component of the vagus nerve?
Correct. I don't think it's the most. I'm not aware of any specific pathology there, so it looks to be. So I don't think it's really affected. So it's really the motor part, as far as I know.
And if you give me questions, what do you think is causing
Well, I'll give my speculation, but we used to say that if I knew that I wouldn't be here. But of course, so. I think it's a really interplay of genetics and environmental factors. The big question is, of course, now is whether there is increasing incidence. I believe, my sort of anecdotal impression was that we are seeing increasing of incidence of Parkinson's disease, even though recent studies show no. But I think it's obviously when James Parkinson, his name was James Parkinson, yeah, James. When James Parkinson saw his cases, walking in London, I mean, the pollution was mostly, so there wasn't much chemical pollution, so there wasn't typical chemical pollution, but clearly there are some genetic risk factors. So the most important risk factor is, of course, age. And, it's about 1% over 65. But it's definitely interplay between environmental exposures. Again, in Kentucky, a lot of pesticides, tobacco growing, even though tobacco growing properly went down. But, drinking water from well, again, idea would be that it's not city water, that it's not untreated, would have more pesticides and genetic component. But I think that is like, as the old Romans say, all roads lead to Rome. So here I would say multiple cascades. I think that it probably looks that, if it leads to alpha-synuclein, aggregation, again, would be best we can come up would be combination of environmental factors such as chemicals, pesticides, and genetic susceptibility. Of course, there are phenomogenic types, including LRRK2 for autosomal dominant, was the most common, even though they are known to have a penetrance, some of these mutations about 30-40%. So there has to be that kind of perfect storm. I think genes gives you, your background, but you have to be exposed to right or rather wrong chemicals, which we still don't fully understand. A lot of these things work as a hit and run. There are some additional factors, physical trauma. Of course, we are in Louisville, and Muhammad Ali, even though, it's kind of different type of Parkinson's disease, but again, so there are definitely evidence for that could lead to tau disruption. But I think that's it's properly it's very non-specific way how the brain responds to different injury, actually how body beginning. There's this idea of course, as you done work, in terms of the spread from the gut. So I think it's basically the best way to answer the question. Parkinson's disease doesn't exist. Let me explain myself. What exists are Parkinson's diseases. I think so. That's probably the best way to answer. We are of course they have a final common pathway, so they don't exist as a singular entity. That's the point. Um, and so I think that of course they would have this final common pathway when they would end up, really this striatal nigra degeneration. And that's why I showed that first or second slide with a substantial nigra. But again, it's multiple, it's no specific way leading to disruption of alpha-synuclein homeostasis. And again, multiple roads lead to REM. So that's what I think is, again. So I don't think it's a single cause, obviously.
Have they studied Rexulti at all for psychosis?
No, but I hope not, because I think it's too strong. It's too strong. So it obviously has an indication for AD. I would avoid that because I think it's very, so I think it's a too strong motor. You probably will see somebody, but I frown upon, I always stop it if I see that. Yes, sir.
Yes, are they worsened it or false?
The good question. I mean, stimulants, again, I didn't find them very useful. Again, you always have to be, is there a component of depression? So sometimes these stimulating antidepressants, Prozac and Paxil, could be used. So typically I like to use non-stimulating for depression in Parkinson's disease, but if something's apathy, I may, go to fluoxetine or paraxfluoxetine. Not much works actually. So again, again, but I think that those are steps. Again, currently we try to really almost like force them to really be active. So it's that's why I mentioned that basically calendar. So pharmacological treatment again, others have really coexisting depression. It's not very, I mean, it's not very helpful. Again, I attempted, but I found that it's really almost like, okay, you have to walk every day 1 mile. I'm just making it up. And you just literally marketing is bring me the log. I mean, don't cheat that you did it, as doctors actually Rabo, the freelance says, owing a stationary bike is not equal to exercise, having one in the basement. But again, but sometimes stimulating antidepressant SSRIs and stimulants like modafinil, try to stay away. That's what I use. Even I didn't show any specific studies, but it's kind of really hit or miss. Pardon? Well, actually, that's but I think that more STN, of course, and so actually, if anything is, especially if you go medial, so STN has like there's this mesolimbic projection of STN, which is medial part of STN. You can actually sometimes induce more almost like mania. I had a few patients who basically become hyperactive. So, but would I dare to start to stimulate to treat that? But that would be one strategy, sort of apathy, pre-existing to go for STN and try to go more medially. But again, I think it's a little bit playing with the fire, in my opinion. Yeah, yes.
I was wondering, is the prevalence of syndrome, Czech Republic, I remember there's patients that were like severe chest, but they still like their dopamine, like a stimulant or something, they like it. So when we were trying to increase it or
So it depends. So I think it's also has to do. So I think that in our practice, Dr. Holiday, I'm not sure she's on. So part of it also has to do with the dosing, and sometimes you escalate. So obviously now levodopa has become. So the incidence is about 10%. And I think that there are some strategies which you can sort of course, some patients are susceptible, but using lower doses of levodopa may be sort of protective. So, for these patients, of course, I would definitely, try lamotrigine, or that's actually my favorite, preferred medication. But again, it's almost like they are becoming almost like addicted. That's correct. But but it's about 10%. But I think that the risk factors would be higher use of agonist dosing and higher use of levodopa. So using what I would call a rational polypharmacy may be a better way to do it than just monotherapy. And so those centers which actually heavily rely on monotherapy, like for instance, North, I'm not sure which direction, I think whatever direction, they, so again, I don't know their numbers, but that's a higher risk. And again, these patients are very difficult. They are almost like addicts, so that's extremely difficult. And again, patients like to be on. And again, if you have a lot of euphoria, that's a trouble. That's a trouble. And for these patients, I would definitely target GPI. I would definitely stay away. Speaking about DPS, going back to Underwood's question, so GPI would be for it, because again, the reason is that you may not have a less medication reduction, but you can at least control the dyskinesias, and again, you don't have this kind of stimulation of mesolimbic system. But again, those are challenging patients. We need to get you back on we need to get you back on a movement disorder track, but it's maybe not too late. I don't see any questions. Hold on, make sure I don't have any on chat. Yeah, so thanks so much. Let me leave.